All right. Good morning, good afternoon, good evening to all our colleagues logging in from around the world. Please remember these sessions are recorded and published on YouTube, so please feel free to watch any sessions you weren't able to attend previously. Today, I have the pleasure of introducing our guest speaker, Dr. Udit Chaddha from Mount Sinai Hospital in New York City, where he's the director of the Pleural Service and associate director of Interventional Pulmonology. He's an active clinician, researcher, and author, and has a prolific number of publications in the full spectrum of topics in interventional pulmonology and pleural disease. He's also involved in national and international societies, developing consensus statements and updating guidelines, and can be found frequently speaking at international conferences. And with all of that, he still finds time to spend time with his family and pick up his son from school. And so without further ado, I'll pass the screen over to Udit, and he's going to discuss with us today intrapleural enzyme therapy for empyema.
Thank you, Dhaval, and thank you to you and Gary for inviting me to speak. It's truly an honor for me. So, one of the main objectives of this talk is to basically describe how I think intrapleural enzyme therapy should be optimized and how you can optimize it in your care in patients with empyema, and consequently, how you can streamline empyema management. I have no relevant conflicts of interest to disclose. So what's the rationale for IET or intrapleural enzyme therapy? So we look at TPA and DNase, and I talk about TPA with DNase because TPA is the only lytic studied in combination with DNase, but really any fibrinolytic should work with DNase. TPA breaks down septations, potentially has a lavage effect. DNase, on the other hand, breaks down extracellular DNA, which reduces viscosity of the pleural fluid. And both of these in combination hopefully help you clear the pleural space better. Now, there may be an additional benefit to using these two in combination, which is breaking down biofilm, which may allow better antibiotic penetration. So the question is, when should you use TPA DNase or intrapleural enzyme therapy? Do you use it initially as initial therapy, which means as soon as an empyema patient hits the door, you place the chest tube, you start intrapleural enzyme therapy, or do you use it as subsequent therapy when your standard care tube thoracostomy and antibiotics fail? Now, one thing I want to highlight from MIST 1 and MIST 2 is that placebo works. So when you do insert a chest tube, the thing I recommend doing is having patients and assessing whether the chest tube works or not. So once you insert a chest tube, you assess for the patency of the tube and you see whether it's draining or not. And within an hour or within sometimes minutes of inserting a tube and flushing it, you know whether the fluid is going to be drained or not. And if it's draining well, then you keep assessing the patient and you continue draining the tube to suction. On the other hand, if the tube is not draining well, and you can make this decision very, very soon with bedside assessment and sometimes even ultrasound, you give TPA DNase. So my suggestion is to use TPA DNase not upfront when the patient hits the door, but very soon after tube thoracostomy if the tube thoracostomy drainage is not working, and that decision can be made within hours. What if you use TPA-DNase upfront in everybody? There are some downsides. One, there's a cost to it. It costs approximately 7,000 US dollars for a 3-day course here. There's some pain associated with administration of TPA-DNase and up to a third of patients. And then there's approximately a 5% bleeding rate. And in a retrospective observational study across 24 centers with almost 1,900 patients, the bleeding rate was also 4%. And 25% of these bleeds needed surgery and 50% needed transfusions. So a hemothorax or hemorrhage post TPA DNase is not necessarily a mild event. So put your chest tube in, assess the patient quickly, but make a very quick decision as to whether you need to give TPA DNase or not. When you see this, when you see septations, extensive septations, does that change the likelihood of you needing TPA DNase? Firstly, I'd like to highlight that across studies, septations are very common in patients with empyema. And in one of the studies, the presence of septations actually did not uh, be associated with the need to give TPA DNase or not. So when you do see septations, maybe you need to give TPA DNase or not, but you cannot make that decision just based on septations alone. Tube thoracostomy alone may work. Again, put your tube in, assess it quickly. If you need to give TPA DNase, give TPA DNase. The next question is what dose? Now we say 10 and 5. That is because 10 milligrams was used in the only randomized control trial, the MIST 2 study. But remember that this was not based on any dose escalation study, and this dose of 10 milligrams of TPA was empirically chosen. Now, the question is, can you lower this dose and maintain efficacy and reduce bleeding rates? Now, I must highlight that there's a small study on 25 horses in which a TPA dose of 3.7 milligrams was sufficient. And you can imagine a horse hemithorax being much larger than a human hemithorax. So why do we need 10 milligrams? And Gary and his group have actually studied this with a 5 milligram dose, and in the ADAPT-2 study, a 2.5 milligram dose. And my understanding is they are further reducing the dose to 1 milligram now. And you can see on this graph on the left that the need for surgery and the successful discharge is pretty much similar to post-mist publications with about 90% success rates. The question is, though, what about the bleeding rate? In ADAPT-1, which is the 5 milligram TPA DNase study, there was a 5% bleeding rate, so not much lower, but again, it's a small study. And in ADAPT-2, there was a 2.9% bleeding rate, which means 2 patients had bleeding, but importantly, only 1 patient at the 2.5 milligram dose had bleeding. In the second patient, the dose was escalated, and then bleeding happened. So maybe lower doses are associated with lesser bleeding, and likely lower doses still maintain efficacy. Overall, though, right now we don't have randomized evidence to say that there is a big difference. What I can suggest, though, is in certain situations, a lower dose may be beneficial. We know from this large retrospective observational study from 24 centers that I mentioned that anticoagulation use almost doubles the rate of bleeding. So maybe that's one situation in which you can start considering a lower dose and escalate up if need be, if the lower dose doesn't work. Now, once you start TPA-DNase, please remember that this is not an antibiotic prescription. You don't need to complete 3 days, 6 doses. In most of the studies, many patients did not complete the 6 doses, and the median number of doses in some studies was 3 and 5. So really, you stop TPA-DNase when you stop needing to give it. So individualize the therapy. And how do you do that? If you have complete radiological resolution of your pleural effusion, it's a no-brainer. There's no reason to give more TPA-DNase at that time. Or if you have decent radiological improvement and clinical defervescence, you still probably are okay and you can stop your TPA DNase intrapleural enzyme therapy administration. Now, what is decent radiological improvement? The problem is this is subjective. However, if someone has clinical defervescence and has a more than significant improvement in their chest X-ray and ultrasound, that should be okay to say that TPA-DNase has worked and is successful. Look at the MISS study, which had a radiological primary outcome. There was a 30% improvement in pleural opacity from day 1 to day 7 in the IET group. But look at the numbers. Very few people had complete radiological resolution. In fact, a very small number of patients had that. And you see this across studies. This is an old study from 2004 in streptokinase alone, where you see the lateral shadowing or the area of shadowing of the hemithorax at the time of discharge is still about 20-30%. And it's only with time that that effusion or residual opacity actually goes away completely. And Gary, following this protocol, has actually shown that if you do this, nobody has recurrent infections, nobody has delayed complications or residual pleural thickening, and all patients of the 62 that he studied actually returned to their prior level of employment. So again, treat empyema not necessarily like an abscess where you have to drain every drop of the pus, but somewhat more like a pneumonia, wherein if you do have some residual consolidation 1 week later, you're not going to send that patient for, a lobectomy or any other further intervention. You're just going to have patients continuing your current therapy and watching them improve if they are already on the right track. Now, in many countries, a DNase is not available. So the question often comes up, what about using fibrinolytic therapy, monotherapy? Now, this is not something that is as well evidence-backed because it lacks a randomized study like MISS-2. And then even in MISS-2, if you look at the TP alone group or you look at the streptokinase alone group in MISS-1, there was not much difference. In a Cochrane review, the mortality difference between fibrinolytic monotherapy and placebo was not seen, but there was overall some benefit in reducing surgical referral rates. However, when the studies with only low bias were looked at, this sensitivity analysis did not hold true, and the benefit for reduced surgical referral rates did not hold. Um, in a 2021 consensus paper, this was addressed, and my current suggestion is much like the recommendations from that paper, wherein if you don't have access to DNAs or DNAs for whatever reason is contraindicated, then fibrinolytic monotherapy can be used, or saline flushing can be considered uh, in patients who are non-surgical candidates. And even in those who are surgical candidates, you can give it a trial while consulting thoracic surgery colleagues to come on board um, and seeing what happens. So the question again now is, what you have TPA DNAs, you've given TPA DNAs or not, when do you operate? Now, IET failure basically is the opposite of success, which means that there is no or minimal radiological improvement, or there is some radiological improvement, but that patient still continues to be septic. So there's lack of clinical defervescence. That's failure of your medication. However, you can assess this within 2 to 3 doses. Within 24 to 48 hours, you know whether intrapleural enzyme therapy is working or not. You do not need to wait all the way till 6 doses, 3 days before saying, oops, IET failed, let's call thoracic surgery on board. So that decision can be made within 24 to 48 hours. So what I am suggesting is you make your decision on TPA DNAs within an hour or so, within the first day for sure, and within 24 to 48 hours, you know whether it's working or not. So if you are consulting thoracic surgery, you are doing that within 2 days of that chest tube being placed. And this is extremely important because the later they operate, the higher the rate of thoracotomies as opposed to minimally invasive VATs being done for decortications. And this is important because you can see in red here, the thoracotomy group has higher length of stay, more procedure time, more morbidity, and more mortality from this STS database. So question is, when do you operate? I'll take you back to MIS 2. There was a 4% surgical referral rate in the IET group. So if you operate upfront with everyone, you are probably going to be operating on a large number of people who would have never needed surgery and could have been treated alone medically with likely the same outcome. Now, what if you have a visceral pleural rind? Now, we do know that stage 2 to stage 3 empyema, stage 3 when the rind comes up, is not clinically a black and white zone. There's a lot of gray zone in between. So it's hard to predict when someone is isolated stage 3, but when you do identify a thick rind, the likelihood of them needing surgery is higher. So in my practice, my threshold to contact thoracic surgery is a little lower when it's clearly a stage 3 empyema. And you can see from this study from 2018 that pleural thickening was one of the main independent predictors for intrapleural enzyme therapy failure in this study. However, you still never know. So I still give intrapleural enzyme therapy a shot before committing a patient to the operating room when we are unsure. So let's take a step back and say that I put a tube in, it's not draining well. Why not operate on everyone up front? Now, I did mention that I think you'd be operating on a lot more people if you did that, but what if surgery has a better outcome? Why not do that? So does upfront surgery when tube thoracostomy fails, how does it compare to medical therapy? Now, William Osler, famous physician, said empyema needs 3 inches of cold steel instead of the fool of a physician. And Dupuytren, on the other hand, did not want surgery despite being a surgeon himself, and both of them died of complications of empyema. In fact, Osler died of post-op hemorrhage. I think on day 5, if I'm right. This question has really been addressed well in only one study, which is only strictly a feasibility study. So we don't have the right answer yet. But MIS 3 for a feasibility study did assess after 24 hours of standard care, randomizing patients to continued standard care, early VATS or early intrapleural enzyme therapy. And even though it's a feasibility study, there's a lot to learn from this. And what they did see is that there was no difference in length of stay in the early VATS group or the early IET group, which is great. And there is basically no difference in reinterventions or readmissions. And there was probably lesser pain and better quality of life in the intrapleural enzyme therapy group, not surprisingly. The time to intervention was longer. In the surgical group, it took 3.5 days for someone to get surgery, which is, I think, a real world situation. There's a lot of different access to surgical groups. It really depends on the day and the time of the week. Is the consult placed on a Monday morning or a Friday afternoon? or a Saturday afternoon. So I do think the 3.5 days is real world experience. And intrapleural enzyme therapy, on the other hand, can be given within an hour of you ordering it. You just need to go to the pharmacy and pick it up. So that's one of the big benefits I want to highlight of intrapleural enzyme therapy. It's something you have literally in your pocket and you can administer it quickly. One of the arguments with this feasibility study was that, what if surgery was done up front? Could the length of stay have been shorter? Who knows, right? This is a feasibility study. You can't make those conclusions. However, there's very few patients I know who would say that you give me the exact same outcome, and maybe I stay in the hospital a day or two longer, but I avoid surgery. And everyone would prefer that option of medical treatment, avoiding surgery with the exact same outcome, even if it meant I stayed in the hospital a day or two longer. So in my book, I don't think surgery and intrapleural enzyme therapy are competing therapies. I don't think we should look at it like that. Even though I do think studies like MIST-4 are necessary, I don't really know how that's going to impact my practice directly, because I do look at both of them as somewhat sequential therapies, not alternatives for each other. So we look at it as you give intrapleural enzyme therapy. If it fails, you give surgery, or you offer surgery to patients, because there are a couple of things we know for sure. Intrapleural enzyme therapy works. After MIST-2, there were 7 or 8 studies that have been published, some prospective, some retrospective, and all of them show that you are avoiding surgery and discharging patients in 90% of the cases in the IET alone group. So we know that intrapleural enzyme therapy works. The second thing we know is delaying surgery hurts. So yes, when IET does fail, you do offer surgery, but you don't want to make that decision 3-5 days after chest tube insertion, or 3-5 days after the patient presents to your emergency room. So the way I manage empyema, again, is you put that chest tube in, start the antibiotics, ultrasound that patient, assess for tube patency. Within an hour or so, you will know whether that tube is draining or not. And if not, then give intrapleural enzyme therapy. Whether you believe in surgery or not, you can call your thoracic surgery colleagues on board right away, or wait. In my practice, we give at least 2 doses of IET to say whether it's working or not. And if it's not working, we call thoracic surgery on board. They book the patient for the OR. If IET continues to work and the patient improves, we cancel the VATS. But again, I think this should be sequentially done rather than IET versus VATS as your first rescue outcome. And keep in mind that success of intrapleural enzyme therapy doesn't necessarily mean complete radiological resolution. You're not trying to drain an abscess here. Even if you have decent radiological improvement and clinical defervescence, that is success. And antibiotics for 2 to 4 weeks, or whatever course you do decide, should suffice in those situations. Well, I think that's my last slide. Thank you.
Brilliant. Thank you so much, Udit, for that. That's a great highlight for, and one of the first questions we frequently ask our guests are, how would you do things in 2025? And I think that last slide pretty much tells us exactly how you would manage these things. So it's really helpful to know, because there's a little bit of gray, like you said, in terms of when to get things involved. And some of it is also local, availability, like you mentioned, if a thoracic surgeon or not. And so, for all our participants that are joining in, feel free to please throw some questions in the chat. And I'll try to go through them as we chat here. But I'll start off, a little bit just to get your thoughts on a few things. So you'd mentioned that you don't have to necessarily complete all 6 doses like we were doing it in MIST-2, and you kind of gave us an idea of defervescence and radiologic improvement. So just a little bit more detail on that. In terms of radiologic improvement, how do you follow that with X-rays? Do you do a low dose CT? Do you do ultrasound before you decide, hey, we're really done?
Yeah. So even in MIST-2, only 2/3 of the patients completed all 6 doses. So practically, I don't think you treat this like a fixed regimen, and you tailor it or individualize it to the patient in front of you. So there's a few things you look at, right? So you look at radiological improvement and you look at clinical defervescence. Now, radiological improvement is best assessed daily by bedside ultrasound. And we do this twice daily in all patients with empyema, where we see for significant improvement. And even if there is a small residual effusion and the patient is clinically improving, we don't really worry about it. We also get daily chest x-rays because remember, point of care ultrasound is something you can see, you can upload a video, but an x-ray is on file for everybody to see. So we do get x-rays. We do not get CT scans because there is always a tendency to find a locule here or there. And then, you're basically tending to treat the image much more than the patient in front of you. So in an improving patient, we do not get CT scans. In patients who are not improving and whom we may consider surgery, or maybe in a rare situation, a second tube placed into a non-draining locule in a persistently septic patient, we'll consider a CT scan. Clinical defervescence, again, you look at basic clinical signs. Are they still tachycardic, febrile? And then we look at improvement of the CRP. Now, how much does the CRP improve? People say about, if it improves up to 50%, it's great. There's no real number. As long as we have a good trend and it sort of fits in with the overall clinical picture, we look at CRP as well.
Perfect, thank you. So we've got a few questions pouring in, so I'm gonna get started with that. I'm not sure how much you'll be able to comment on the pediatric population, but one of the first questions is how will your approach be different for children? Any comments? I know you're not a pediatrician, and it's very separate in the U.S. So
Yeah, no, I don't have any specific comments. I don't treat pediatric patients with this disease.
yeah, so sorry not to answer that. It would just in the U.S. the practice is quite different. I can tell you from my experience. So we will go on to the next question then. What dose of fibrinolysis would you recommend for infected retained hemothorax? Would you give alteplase alone or together with DNase as well?
Yeah, so that's uh, if it's infected, then you're treating it like an empyema at that point. So I would give TPA and DNase because at that point your goal is not only to break septations but also reduce viscosity to allow for better drainage. And I don't know if the question was alluding to this, but in a retained hemothorax alone, the usual dose is 4 milligrams. Again, not studied in randomized settings, but there's a lot of other smaller studies that look at this, and about 4 milligrams of TPA should be enough. Again, in empyema too, 4 and lower should be enough too. It's just that we have a randomly picked 10 milligram dose in a randomized study, which makes that the standard of care dose. But lower doses, as Gary has shown, should be enough even in the setting of empyema. But I would give DNase as well, yes, if you think the hemothorax is infected.
Yeah, no, absolutely. And I think, you don't lose much in, starting low, going slow kind of thing. You can always ramp up if you're not getting response. You're doing this twice a day. Like you said, you can ultrasound these bedside. You get real point of care information right away. So you can, as long as you're monitoring these patients
Yeah.
regularly, there shouldn't be any significant delay, I think,
Correct. And just to stress a little bit more on the twice a day thing, right? Let's say my first dose was given at noon and I leave at 7 p.m. I'm not waiting till midnight to give my second dose. We don't know the exact pharmacokinetics of TPA in the pleural space, but if in the serum it's seconds, it can't be that long in the pleural space. You clamp the tube for an hour based on some ultrasound data that yes, it takes about an hour for everything to mix around and have a good effect. But 7 hours later, that's fine. So you don't have to wait till the next day to give your next dose as long as it's sufficiently spread from your first one. So if my first 2.5 dose doesn't work, I can try 5, 10, whatever, maybe the same day later on and not wait till the next day. Because again, delaying is again one of the few things we know again is delaying surgery or delaying the next salvage outcome, which in this case is surgery, is associated with more morbidity and sometimes mortality.
Great. So the next question is then, what is your typical duration of antibiotics, or when do you swap to oral? Is there any kind of clinical indicators that help you allude to when you do that?
Yeah, so without getting into the details, there are two studies looking at shorter courses of antibiotics, which is 2 weeks, but they do exclude a lot of people who are very sick. In my practice, those studies have not changed what I do. What I do is very simple. I do 2 weeks after clinical defervescence. That is my standard. So inevitably, people are getting up to 3 to 4 weeks of antibiotics. Again, we are not de-escalating based on the bug we grow, unless it's something that tends to be monomicrobial like strep pneumo. We are continuing patients on a broad spectrum antibiotics like coamoxiclav if they have routine strep or anything growing to cover anaerobes, as well as many of these infections tend to be polymicrobial. In patients who um, are elderly, cannot undergo surgery, have trapped lung, we'll reassess them in the office every week. But at the end of 2, 3, 4 weeks, sometimes we may extend the therapy by another week or two, just to make sure that there is no residual infection left behind. But again, my standard is 2 weeks after clinical defervescence.
And then the other part of that question is, when do you consider swapping to orals from IV?
Just before they're ready for discharge.
All right. The next question is, do you have a minimal chest tube size that you prefer if you're going to give TPA DNAs?
This has been studied to some extent, not directly as a primary outcome in a study, but we do know that large bore tubes probably hurt more and probably don't add much value. The only caveat there being that if you put a small bore tube, you should be flushing it because they're more prone to getting clogged. So a large bore tube is not equal to a small bore tube. A large bore tube is equal to a small bore tube that is being flushed when clogged. Now, whether we need to flush it 3 times a day, 2 times a day, 4 times a day, we don't know that. Or flush it PRN, but a small bore tube does need to be flushed in case it does get clogged. So yes, there is no minimal tube size. We do use 14 French tubes over here, but 14 is probably equal to 12 is equal to 16. I don't see the benefit in going larger. The only time I would put a larger tube is, initially when we do our needle aspiration, if we have very thick viscous pus, I maybe put a 20, 24 French in there, but that's not backed by any evidence. Yes, on the other extreme, you don't want to put an 8 French tube, right? The smaller you go, the more likely that tube is going to clog and will need more management. So about 14 French should suffice in most cases.
No, and exactly. That's what I've always kind of grown up using, and I love it. I think it's a perfect middle ground. It's a decent size, not as much pain, and I don't know that you get much less pain with an 8 when you go to compared to a 14 necessarily from my experiences. So yeah, I agree. I think that's probably a reasonable size to start with. But interesting to know that the approach of kind of at the bedside, kind of figuring out what am I going to use if it is thicker. So I mean, that's I think probably more helpful to determine. Again, not research, no heavily extensively studied, but definitely something again. And I think it just highlights the point of how much you can really make a decision at the bedside when you're clinically evaluating the patient and what's going on in front of you. So great. All right, a few more questions. I'm going to try to get through them for us. So some thoracic surgeons are hesitant to operate on patients who failed fibrinolytic therapy in view of the risk of bleeding intraoperatively. And thoughts on how you discuss that, or how you convince them, or what conversation do you have with your thoracic surgeons?
I mean, I've had numerous conversations with colleagues around the world now, and we get different answers. I would say most thoracic surgeons say that it actually makes the surgery easier, not more difficult. And I can't imagine a reason why it would make surgery more difficult. Again, the medications have a very short half-life. TPA has a half-life of seconds in the blood, and probably very short in the pleural space as well. We don't know exactly how long, but it's not lasting days. So there should be no residual effect of TPA DNAs in the pleural space when they go to operate. If anything, it should make things easier because it may thin out some, thick secretions, thin out some rind, make some septated spaces more monolocular. But I don't see how TPA can make things worse. And my surgeons actually do prefer giving it before we schedule them for the operating room. One, because they don't think it makes things worse, it may make things better. And two, very often we cancel surgeries based on that. If you look at the feasibility MIS3 study, I think about 35% of their patients in the VATS group had surgery canceled as the surgeon themselves determined that the patient is already getting better and does not need surgery.
Yeah, and I think
So,
that's
so, so, so
pretty.
surgery should not be a reason not to
Yeah.
give TPA DNAs. Let me just reemphasize that.
No, absolutely. And I think and the big thing, like you highlighted, is just talking with your surgeons early on, and then kind of developing a relationship with them. Because you're right, I've had the same experience as you say. Where in training, my surgeons loved us to do TPA DNAs first because they thought it actually made the pleural rind easier and like easier to peel, and kind of if there was anything, made it actually better for them. Whereas conferences, other surgeons saying, no, absolutely hate it, don't like it. Similar, they said bleeding risk and all these kinds of things. And this was a few years ago. But again, I think it's important to just kind of get involved with your surgeons and have a discussion with them early, and get them involved kind of up front. So yeah. All right. Next question then is, could you comment on the role of a second chest drain plus or minus TPA versus VATS? So I'm assuming in a second lockule or something like that, I presume is maybe what we're getting at. But yeah.
Mhm. Yeah, again, if you go ahead and get CAT scans on everyone after your medical pleural treatment, you're going to see some residual collections, often some untreated locules. So the only time to target a large undraining locule is if there has been no clinical defervescence. So that's something to keep in mind. And if it does come down to that, where you think that there's a single locule that is responsible, number one, I do always get a CAT scan to make sure that there's nothing else going on.
Mhm.
And we would then consider an image-guided tube. But at that point, we already have our thoracic surgery colleagues on board to say that, listen, we're going to try this tube. Maybe it works for a day in this undraining locule. If not, this patient probably needs the operating room. But again, as we know, many of these patients are surgical candidates. So non-draining locules, if large and patient hasn't clinically defervesced, we routinely place image-guided tubes into those locules. And image-guided doesn't mean CT guided. It could be ultrasound guided if you see the locule well enough and is easily targetable, depending on your level of comfort in placing sonogram-directed tubes.
And in the new locule, then would you consider doing intrapleural therapy again in that secondary locule? If
Yes,
it wasn't.
I'm not opposed to doing that. Yeah, again, anecdotally, there's been no issues. I think, of course, with every dose, you reinvent your risk of bleeding. So keep that in mind. For me, TPA DNA is a consent. We consent patients for that, though it's not really a procedure. There is
Mhm.
some risk to giving it. It's like consenting someone for chemotherapy. So we do consent patients, but we will give TPA DNAs in a second locule if we need to.
Absolutely. And then the next and hopefully probably last questions, because I don't want to go too over time, but one more question for you. I want to get back to sleep. So how do you approach a non-expanded lung after treating with TPA DNAs with otherwise good clinical biochemical response? Do you tend to monitor or advocate for VATS?
Yeah, it depends on how much non-expandable lung there is and how old and healthy your patient is. So in a young patient with a large, um, you know, trapped component, the threshold to send that patient for a decortication will be lower, as opposed to in an elderly patient or in someone with a small um, trapped component. So just the very fact that you have non-expandable lung alone doesn't sway me to send the patient to the operating room, because we do see the rind thinning out with medical treatment, antibiotics over weeks, and the lung expanding. But again, in a younger patient, if that amount of lung is large, the trapped lung component is large, then we would have a lower threshold to send them to surgery early, which means during the same hospitalization. Again, I'm using vague terms like large, old, young. Again, this is all an art and it's all a spectrum. I mean, and no guideline can best advise you on these things. These are all assessed by the clinician at the bedside, factoring in the patient and the scenario that they're dealing with upfront.
Absolutely. Perfect. Thank you. And I promise one last, but I'll give you one more and then I'll let you go. But, there's case reports and case series probably even published, but in terms of our colleagues that may be in rural or areas where the thoracic surgery is just not available, thoughts on fluoroscopy for management of kind of an undraining or there's stuff left in there. Thoughts on that?
Yeah, I'll try to be short with this. This can be a talk in itself. Um, what we do know from the fluoroscopy literature is that when you do medical thoracoscopy for empyema, even if you select patients with stage 2 empyema, in about 1 to 4 to 1 to 5, you are failing. So if you do have VATS expertise and the patient is a surgical candidate and you do determine that that patient needs VATS, at that point, it is unreasonable to do a medical thoracoscopy. So a medical thoracoscopy is not a replacement for VATS in someone who is a surgical candidate. In someone who is not a surgical candidate, or if surgical expertise is not available, early medical thoracoscopy, which means still within that 2, 3, 4 day time period, is a reasonable option, understanding that you may fail 20% of the time. So it's a consent with the patient. Have I done medical thoracoscopy for empyema several times, but it is not my standard of care. My standard of care is intrapleural enzyme therapy. If that fails, very quickly send them over to surgery. On the other hand, if surgery is unavailable, they're not surgical candidates, I will very quickly take them over to medical thoracoscopy, understanding my limitations that I cannot peel a visceral pleural rind, and it's tough to determine what to get into. I have great videos on this where clinically and sonographically and tomographically, space looks exactly the same, but when you get in there, one is necrotic mush and the other is an easy effusion to drain. So, you never know when you need to, get someone with surgical expertise in, because even they need to convert to thoracotomies 10 to 20% of the time. So short answer, yes, it can be used, but do it early if VATS is not available.
Absolutely. Perfect. Thank you for that. Thank you for your time and thank you for presenting today. With this, I will conclude the session today. And just as another reminder, please remember these sessions are recorded and you can catch up on YouTube any old sessions that you missed or wanted to rewatch. And join us again, please, next month for a new topic. And we'll see you then. Thank you, Udit. Take care.
Thank you.
All righty.